Along with Kelly. I'm Linda Gaudiani. I'm the medical director and co-founder of the Braden Diabetes Center. And on behalf of myself, Kelly, our clinical nurse manager, my co-founder, friend, and supporter, Bruce Braden, who's with us today as well, and our speaker, we'd all like to say thank you for joining this very unique, our first virtual town hall meeting. I want to tell you just a little bit of the history of the Braden Fall Fest. It's really a very unique event at the hospital, I think. We had our first Fall Fest in 2015, which was as a culmination celebration of the end of our first year as Marin Health Center's first truly outpatient service center. And we decided to have a grand party, and we decided to invite not only our entire professional medical community for a very high level CME, Meet the Professor medical lecture, but in consideration of diabetes as the quintessential team managed condition, we decided why not invite the entire community of our patients as well, their families and their friends. And indeed, we gathered together for educational presentations in the afternoon, culminating in our CME lecture, and then physicians sitting next to patients, our Q&A. And it was so successful that we decided that we'd continue it, and we have. And with a bit of persistence, but mostly grace and generosity on the part of the speakers that we knocked on the doors of, we continued to have a star-studded group of the most world-renowned and celebrated diabetes researchers, clinicians, academic professors, and educators really in the world. We started with Dr. Earl Hirsch from University of Washington, who's been our supporter and mentor in the development of the Braden Center from the beginning, and a shout out to Earl for being our first speaker and for celebrating our 5th last year with us and speaking again. Also to Dr. Matthias Hebruck at UCSF, to Dr. Salih Adi, formerly at the Madison Pediatric Diabetes Clinic at UCSF, to Dr. Robert Rushikoff, who informed us about technologies update, and finally to the illustrious Stephen Kahn. Fast forward to last fall, 2019. We had covered the newest insulins, the newest medications, the latest innovative technologies, the automated insulin devices. And yet we still could not explain the slow progression in stemming the tide of new cases of prediabetes and diabetes, or really of doing as much as we wanted to slow the incidence of diabetic complications and to optimize diabetic control and quality of life as much as we wanted to. The topic of diabetic distress began to emerge more and more strongly in my mind, and I decided last fall that diabetes distress would be the topic of this year's Braden Diabetes Fall Fest. Forward to late winter and early spring 2020, who knew that it would bring a worldwide pandemic that threatened and put at risk an already at-risk population, the population that we serve, our diabetics. So we are bringing you this evening to really focus on what is diabetes distress, and how is it especially difficult in this time of COVID. What can we as clinicians do to lessen that and to improve outcomes? What can we do as patients to work with our clinicians towards these ends? Again, with gratitude and grace, a request to the leader in this field in the country and maybe in the world, Dr. William Polanski, who joins us today, was met with an affirmative, and he joins us to talk about this topic with an incredible wealth of experience. Just a little tiny bit on his background. Professor Polanski is now Associate Clinical Professor in the Department of Medicine, Division of Endocrinology and Metabolism at University of California, San Diego. He is also the founder and president of the Behavioral Diabetes Institute in San Diego, period. And he received his PhD in clinical psychology at Yale University in New Haven, but I was interested to see he has a lot of roots in California and received his BA at our University of California, Santa Cruz. His CV is so impressive in the depth of research that he has participated in and led for decades in this topic. And I would say that it culminated, perhaps in terms of awards, in these most prestigious awards in 2014, the American Diabetes Association's Richard R. Rubin Award for Distinguished Contributions to Behavioral Medicine and Psychology. And this year, many congratulations, Dr. Polanski, Bill, for receiving the American Diabetes Outstanding Diabetes Educator Award. So without further ado, and with much pleasure and thanks, I will turn you over to my colleague and now friend, who has been amazingly patient as we have tried to piece this novel format together. Thank you for being patient with us, and I will now try to click myself on, and hopefully Dr. Polanski will bring up his slides, bring up his own video, and when it's concluded, all of the panelists will come back to speak with you and to interact with you, hopefully in a wonderful brief Q&A period. Bill, thank you. I'll turn it over to you.
Thank you. I'm actually hoping you can all hear me. I'm sure Kelly in particular, if you can't hear me or see me, let me know. But I'm really glad to be here. I actually wish I could really be there. So as you heard, my name is Bill Polanski. I have a special mission tonight. I'm going to bring up my slides in a moment. I'm here to talk to those of you who are healthcare providers, but I'm also here to talk to those of you who are just people with diabetes or love someone who has diabetes. And I'm going to be thinking a lot about speaking to healthcare providers tonight. You'll realize that when you see my very first title slide. And I'm going to do my best to speak for those of you who have diabetes and those of you who care for someone who has diabetes. And I'm hoping when I wrap up and we have time for Q&A, you can let me know whether I spoke well for you or not. I'm going to do my best, as best as I can, to minimize my typical medical healthcare jargon so everything's pretty clear, and we'll see how that goes. So let me start by doing the obvious thing, which is by bringing up my slides. Let's see if I can do that. Hopefully you can see my first slide right here. So here's the title. Hey, why aren't my patients following my brilliant recommendations? We're going to look at sort of communication strategies. And as Dr. G said, the purpose of this is to really look at what's tough for folks living with diabetes every day, which is really about diabetes distress and how we can address that. And to get started, and this is something that actually Dr. G already mentioned, but I want to highlight this point. The reason we want to talk about it is because we know we have a big problem. And the problem is simply this. This is data from a large representative data set called the NHANES system, where we look at how are people with diabetes, and this is predominantly people with type 2 diabetes in this system, how are people really doing in terms of getting to a safe place with their numbers, their A1C, their blood pressures, their cholesterol levels, and more. And there's a lot of stuff on this slide. This is the most recent data we have. But the most important thing, I'm going to cut to the chase here, is that dark blue column on the far right. And you can see I'm drawing a circle around it, and that's 25%. And what that is, it's 25% of people with diabetes in this country are meeting all three of the major ADA treatment targets. Or to put it in English, 25% of people are in a safe place, metabolically speaking. And that means they have an A1C under 7%. Their blood pressure, the goals keep changing, but it's now over 140 over 80, I think. Their LDL cholesterol, LDL is the lousy cholesterol, is under 100. So only 25% of people with diabetes in this country are there. 75% aren't there yet, which tells us how much concern we have. All those people are much more higher, more elevated risk for running into long-term complications down the road. So if you work in the field of diabetes, I guarantee you, you're going to have a job for the rest of your life. There's a lot of work for us all to do, and that's what we want to focus on. And by the way, I've been presenting NHANES data for decades. I should also mention, things are better. First time I ever presented NHANES data in the 90s, I think we were at about 9% of people who were in a safe place, metabolically speaking, meeting all these treatment targets. Now we're up to 25%. Things are actually a little better. So what's the problem? Why are so many folks in an unsafe place? Well, there's a bunch of possible reasons. One is there's macroeconomic factors like poverty. If you can't afford your medications, if you can't afford decent healthcare, if you can't afford insurance, yeah, it's going to be a lot harder to get to a safe place with your diabetes. There's the limitations of currently available tools. We've got great drugs, we have great devices. They aren't perfect. And there's and we'll mention some of those constraints and limitations that make this difficult today as well. Oftentimes the problem is not what the patients are not doing, it's what the healthcare providers aren't doing. And one of the things we often talk about is clinical inertia. So if you're working with a healthcare provider who is, busy primary care doctor and they have to know about everything, they may not be as up to speed on diabetes as they need to be. They may not be as aggressive as they need to be to help you get to that safer place with your diabetes by recommending the best medications, moving that along as urgently as possible. And then finally, the very last thing on the slide, and we're going to focus on this, is, to be fair, patient behavior, right? People with diabetes, what you're actually doing. Now, we tend to think that's the only reason why people end up with poor blood sugar control or high blood pressure. It's not the only reason, but it's a big one. So it's to what degree people are engaged with their own diabetes self-management, but are getting the support they need and have the resources available. Now, when we look at healthcare providers and we say, look, you have a lot of, I go back to the initial title of my slide, of the first slide of my talk, why do you think so many of your patients aren't following your recommendations? What do you think the real problem is? And what we have found, because we've actually published on this, is when we survey healthcare providers across the United States, they don't typically say, oh, look, it's all these 4 factors. They tend to focus on the last one. So the top 5 complaints are these. Well, my patients say they want to change, but they're not really willing to make the necessary changes. They're not honest. They only tell me what I want to hear. They don't listen to my advice. They don't understand diabetes as a priority. They're not interested. They're in denial. They don't care. They're unmotivated. They don't take responsibility for what they need to be doing. Now, the problem with these very, very common attributions, that the way many of us healthcare providers think about people with diabetes, number one, is that they're typically wrong, and they're also not very nice. It's a way of thinking about people, about other people, in a way that we don't think about ourselves. And the theme to these typical beliefs or attributions about people with diabetes, the underlying theme is that if you're not managing your diabetes effectively, or if you're not in, again, that safe place with your A1C, blood pressure, and lipids and more, what it means is that you're a sinner. You're a bad person. That's why you got diabetes, especially type 2 diabetes. You sinned. The reason your blood sugars are out of control is because you're a bad person. That's not fair and not accurate. And yet it's really common to think that way about people with diabetes. And think about how peculiar that is. We don't tend to blame people for getting rheumatoid arthritis. We don't tend to blame people for getting other types of chronic illnesses, typically. And yet, somehow in our heart of hearts, we think it's okay to blame people for getting type 2 diabetes or blame people for not taking good care of themselves. That's not nice. And it also leads to strategies for intervening that don't work very well. And it leads to people with diabetes feeling terrible, feeling blamed and shamed. And perhaps you've had patients of your own who've come in and sat in your office and said, oh, you're not going to want to talk to me today. I've been bad. Or canceling appointments and not showing up. And again, it's this blaming and shaming that's going on, sometimes overtly, sometimes covertly, that really makes it difficult for us to be successful and to help our patients do well. So let's put some of these common and inaccurate attributions aside and talk a little bit about real life with diabetes. So here's some of the important things I want to say. Number one, let's acknowledge this first truth, which is this. Living with diabetes can be tough. And I'm talking about type 1 or type 2 diabetes. This is tough. And it's tough for a bunch of reasons. Number one, it's a job. It's a time-consuming job. The day you develop diabetes, the universe just said to you, congratulations, welcome to diabetes. I have a new job for you to do. It's going to take a fair amount of effort. Oh, by the way, there's no pay, there's no vacations, and you get to do it for the rest of your life. So good luck with that. So that's tough. And by the way, we've had colleagues over the past years who've tried to think about what is the job of diabetes? What are the efforts people have to make, the extra work people have to do, the other things you have to, maybe it's not actual work, but the other things you have to think about, ways you may have to transform your life if you're going to be successful. And they thought about it not just for diabetes, but really for chronic healthcare conditions. And they said, and these authors, they said, there's really this burden of living with a chronic illness like diabetes because it's work, because it's effort, because it's other things you need to think about. And they tried to put it together in this really lovely article they wrote. And they talked about what they call the taxonomy of burden, to understand all these different elements and the stuff you got to do. And they came up with this figure to try and illustrate the burden of a chronic illness like diabetes. And here's what they came up with. Now, I hope you can all read this carefully. Actually, just kidding. This is unreadable. Even if I sent you the publication right now, the font is so small, it's almost impossible to read. And that's not the reason I'm showing it to you. I'm showing this to you to simply illustrate that there's a lot of stuff you got to think about and do. And no wonder it's tough. No wonder it can be hard to manage diabetes because it's a job. It's doable, but it's a job and it can be tough. And it's a balancing act that requires attention and vigilance, and sometimes an ability to deal with frustration. You know, for many people living every day with diabetes, really, especially if you're on insulin, if you have type 1 diabetes, it can feel like this. You know, God forbid you don't want to go too far to the left or right, and you have to be paying attention all the time. You know, one of my colleagues, a well-known type 1 diabetes blogger, when she does presentations, she likes to have little gifts that say, this is how I think about diabetes. This is what diabetes is like for me in my life. And she's someone who is very knowledgeable about diabetes and had it for a very long time. And even despite all that experience and knowledge, she says, this describes for me what I often feel like every day with my diabetes. Despite my best efforts, I don't know, my blood sugars are going up, they're going down, they're going sideways. I'm on a diet, I can't lose weight, the scale never moves, it goes in a weird direction. There's this sense of feeling out of control, of feeling lost, of feeling confused. So if you've ever felt like that and you have diabetes, you're normal. So we're talking about a job that takes time, that requires vigilance and attention, and can really be very frustrating. Now, this is not to say it's not doable, but let's just recognize that this, and be respectful of the fact that our patients are dealing with all of this work. It's doable, but we have to also remember that we're asking our patients with diabetes to take on the job of taking good care of yourself. And it's not the only job they have. Take this job and add it on to all of your other life responsibilities. It's one more job. It's one more thing. Hopefully this isn't representative of anybody's family who's listening right now, but it's to illustrate just again that we have other pressures in our lives, other things that demand our time to make sure I get my mortgage paid, to make sure that my kids don't starve, things like that. So the bottom line is this. When we look at this broad issue of motivation in diabetes, what we can say and really know is the truth is this. Nobody is unmotivated to live a long and healthy life. Not any of you, not me. Nobody's unmotivated to live a long and healthy life. And we should stop accusing our people with diabetes of being unmotivated. The problem is simply this, that the obstacles to diabetes self-management, the stuff you got to do, the remembering to take meds, the trying to follow a diabetes-friendly way of eating, regular physical activity, glucose monitoring, finding all perfect balance, having a lot of medical appointments, the stuff you got to do, the obstacles simply outweigh what is believed or perceived to be the actual possible benefits. Now, there's a lot of awesome benefits, but oftentimes they're down the road, like avoiding long-term complications. That's wonderful. But we as human beings, unfortunately, respond better to immediate incentives, especially positive incentives. That's why there's a place called Las Vegas, by the way. So there's a lot of benefits in diabetes are longer term, but a lot of the obstacles are big and they're in your face, and they're now, and there's a ton of them. And a lot of the obstacles that our patients face really are about this idea of, I'm not so sure that what you're asking me to do is worthwhile. It's this lack of worthwhileness. And there's a number of elements that I want to highlight. I'm highlighting them because it leads to us to begin to talk practically about strategies and things we can do. So obstacle number one is this. We're dealing with a disease that's pretty much invisible, and especially when we talk about type 2 diabetes, often considered to be not very urgent, right? High blood sugars typically don't hurt. Kind of easy to let time go by and not do anything about it. If high blood sugars were incredibly painful, people would really treat this disease quite differently. Let me highlight that with a quote from someone I met many years ago who said this. He goes, look, doc, I know this is serious, but I promise you, I'll start worrying about my diabetes as soon as something falls off. So that's one issue we have to consider, how we address that. Another issue is hopelessness. People often feel doomed by diabetes. Maybe they've had family members and seen terrible things happen to them, or they've read stories or seen something in the news about someone dying of diabetes. It's easy to start feeling quite despairing. And again, here's someone I met not too long ago who said this, what's the difference? Why put out effort to manage this disease? This disease is going to get me no matter what I do. And if you're feeling that sense of powerlessness, you can see why that would sort of suck the oomph right out of you. Another major element is just discouragement. And that was really captured in that little GIF I just showed you. Here's an example from one of my patients who said, I can't believe this. I did everything I was supposed to. And now you're telling me I have to take even more medications? This is someone with type 2 diabetes. And no one had bothered explaining to her that over the course of time, type 2 diabetes can get harder to handle. And odds are good, you might be needing higher dosages, more medications, not because you've done anything wrong, because that's the nature of type 2 diabetes, although it's starting to change. So these are some of the elements that are really of major concern, and especially this last one about the issue of medications. As you may have noticed, none of us, whether you're a healthcare provider or a person with diabetes, are real thrilled about taking prescribed medications. And if you've had diabetes for quite a long time, or you're getting older like any of us, odds are pretty good you're probably taking more meds too. And there's this discomfort with that we're going to talk about. And this leads to the idea of diabetes distress, how you can begin to feel kind of beaten down by diabetes. And the concept of diabetes distress, something we've been researching now for 25 years, is this. It's this felt burden of living with a tough and demanding disease. Now, not everybody has to feel this, but most people, at least to some extent, have been through times when they experience this. And it can involve the elements like we just talked about: despair, feel like I'm going to end up with serious complications no matter what I do, feeling discouraged, I just feel like I'm failing with my diabetes, feeling overwhelmed, just feel like this disease is taking up too much of my mental and physical energy every single day. And these quotes, by the way, are actually items on one of the major questionnaires of how we measure diabetes distress. So we have questionnaires that we've used in the United States and around the world, so we have a pretty good sense of how common elevated levels of diabetes distress are. And the good news is it's not everybody, but our best evidence from here in the US, many of the studies were done, by the way, in San Francisco, is about 35 to 40% of people with diabetes are walking around with elevated levels of diabetes distress. So that's a lot of folks. And we know it's often chronic, that if we don't do anything about it, it just continues for years. And we know it's linked to poor self-care, and it's linked to poor glycemic control. So people who score high in diabetes distress tend to have higher A1Cs, they tend to be more disengaged from their diabetes. We tend to think there's a link like that between depression and some of these things, but actually depression isn't necessarily linked. It's diabetes distress that's really key. So I could talk about this forever, but let's get to the important stuff. That's nice, but what do we do about this? So let me put out some pretty straightforward strategies of what we learned and see if any of those strike you as something that you might be able to use. Maybe some of them you're already doing, which is great. So the first strategy, and by the way, I should tell you, my major colleague who's worked with me in this field of diabetes distress and done all the research is my colleague, Larry Fisher, who's at the University of California, San Francisco, and actually lives right in Marin. So he's probably up the street from many of you. So here's the strategies. Number one is we need to assess. And what that means is anytime you see anybody who's living every day with diabetes, it's a nice thing. Not only is it useful, but it's just nice to ask them about diabetes distress. And we have formal ways of doing it, but the most abbreviated and informal way is to ask this question. Mrs. Smith, it's nice to see you. Can you tell me one thing about diabetes that's driving you crazy? And notice I have the one finger here in my hand and one finger on the slide. And the reason I do this, I always say use one finger, is because for many of you, you have a waiting room full of people and you're often terrified to open Pandora's box. Oh my God, if I start asking my patient what's driving them crazy, it's going to take an hour. And it might. And because your time is limited and you don't want to take on too much at once, you don't have to ask about everything, but say, can you tell me what's one thing about diabetes that's driving you crazy? Just one. We'll get to all of them. We'll see each other again. But let's start with one. And we're asking that in a particular way. We're not saying, hey, by the way, anything bothering you about your diabetes? We ask it in this way. What's one thing about diabetes that's driving you crazy? Because the way of asking this question normalizes that it's very likely that you will have something that's driving you crazy. So it makes it okay for the person to respond. And by the way, I can tell you, I've used this question with everybody I've seen for the past 30 years now, and I still haven't met anybody who said, can't really think of anything. So you're going to open the door to a conversation, but you can keep that time limited, but it's really a very powerful and effective thing to do. I'm going to tell you why in a few moments. Now, you can also do it the more formal way. And when we talk about the more formal way, that means using these self-report questionnaires or self-report instruments. And there's a bunch of them. Of course, the ones I think are the best are the ones that we've developed. And in terms of measuring diabetes distress or using what we call the diabetes distress questionnaire, you can do that quite easily online. This is all completely free, by the way. You can just go to this website, diabetesdistress.org. When I'm seeing my patients, I just bring it up on my phone usually and hand my phone to the person sitting in front of me, and we'll go through a couple screens till we get to the actual questionnaire. They'll fill it out. It's automatically scored. There's two questionnaires. There's the DDS, which is primarily for people with type 2 diabetes, and then our newer one, the T1 DDS, for people with type 1 diabetes. And so far, we just have them in English and Spanish. So if I walked through having someone fill out the DDS, primarily for type 2, and had them fill it out, it would give us this summary score. This was for one of our patients. Now, anything higher of a mean score higher than 2.0, this is a 17-item scale, tells us that person has a moderate level of distress. If it's higher than 3.0, that tells us it's a high level of distress. So we can start just by looking at their total score, and you can see was 3.71. This person is pretty highly distressed about their diabetes. And what you see down here, these other 4 scales are the subscales. So it begins to inform us about where their distress really is. So this person scores high, especially on emotional burden. This is someone who's likely feeling powerless, helpless, hopeless, fearful about what's going to happen to her, discouraged, etc. And you also have a physician distress, how distressed they are about the regimen, which is also quite high, this person, as well as interpersonal distress. So they feel isolated, they feel bugged by their family members, etc. And opening this door and having this conversation can be very, very powerful. Now, my colleagues at UC San Francisco did a beautiful study called the T1 Redeem study. And part of that study was actually asking these questions, asking people about diabetes distress. Here's what one person responded. She said, it was totally unexpected and surprising. She said, I've had diabetes, type 1, for 35 years. In all that time, no one has ever asked me what it was like for me to have diabetes and what it was about diabetes that I found most distressing. And even if they did ask, I doubt they would have taken the time or had the interest to listen carefully to my answer. So even if you can't fix the problem, just asking is an enormously wonderful and powerful thing to do, even if you have limited time with your patients. And when you do that, once you assess, step 2 is you want to respond with some empathy. You don't have to fix the person's feelings, but you want to take a minute or two to listen well and do your best to appreciate diabetes from your patient's perspective. Now, I know that sounds completely impractical if you have a waiting room full of people already out there, but I'm saying just even a minute to do this can be very powerful. Now, again, I want to be clear with you. It isn't just that this is nice, that there's enormous clinical benefit from doing this. And to highlight that, I want to tell you about one of the most amazing studies I've seen in the past few years. And it's a study from the UK. The first author's name is Damba Miller. And what they did is this. They looked at hundreds and hundreds of newly diagnosed type 2 diabetes patients. They'd all been diagnosed within about the past year. They had type 2 for about a year. And they surveyed them and say, tell us about your relationship with healthcare provider. And they said, please score your healthcare provider along these 10 dimensions. The degree to which you feel like your healthcare provider makes you feel at ease, listens to your story, really listens, is interested in you as a whole person, fully understand your concerns. You can see the rest. And it really is picking up to what degree did this person with diabetes see that their healthcare provider had some empathy and really cared about them as a person. But here's the remarkable thing. They then followed this group of, I think it was 600, 700, 800 people with type 2 diabetes. They then followed them for the next 10 years. And they looked at one particular health outcome that we think is the most important one, and that's death. And they said, was there anything about how these people scored and rated their healthcare provider 10 years earlier about whether or not they were still alive 10 years later? Amazing study. Here's the results. I'm going to read it to you. In this 10-year follow-up of patients with newly diagnosed type 2 diabetes, those reporting better experiences of empathy in the first 12 months after diagnosis had a significantly lower risk. I want you to see what's in parentheses here. 40 to 50% of all-cause mortality over the subsequent 10 years compared with those who experienced low practitioner empathy. I want to be clear with you about this. We're talking about a 40 to 50% reduction in mortality over a 10-year period. That's pretty extraordinary based on the degree to which people felt connected, cared for by their healthcare provider. So this is real stuff. Now, to be fair, this study has never been replicated yet. It's pretty new, but it's extraordinary. It tells us this squishy, touchy-feely stuff. Treating your patients not like a number, but a person really matters. So that's step 2. Here's step 3. What about making this invisible disease visible for folks? So here's how we do it. Now, this is a scorecard. We don't typically call it a scorecard anymore, that we developed for one of the healthcare systems here in San Diego. And what we would do, so this is Molly's scorecard, and we keep it as simple as possible. Many of you may be using something similar at this point. You can see we just focused on these 3 elements, A1C, blood pressure, and lipids on the far left. Molly had targets that she and her doctor set together. You can see the next column are Molly's goals, like her A1C target was 7.0% or less. The third column, you can see how Molly's doing right now, her last numbers. Her last A1C was 8.7%, her last blood pressure 125/75, LDL 116. And then we made a totally accidental discovery. We would fill out everything on the left, and then we would give Molly a pen because the green column and the red column were blank. And we said, Molly, let's start with A1C. Could you please put a check mark if you think in the green column, if you think you're in a safe place with your blood sugar, or in the red column, if you think you're not yet in a safe place. And if Molly wasn't clear about what an A1C is, we'd explain it to her and talk about it. And it turns out when Molly put that X in the red zone, it was very powerful. It wasn't us telling Molly that she was in an unsafe place. It was Molly telling Molly she was in an unsafe place. And what her response was, and this was true for most people, is they'd say, well, this isn't okay. What are we going to do about this? And it really transformed our conversation. I remember Molly saying, oh, maybe I need to start taking those medications my doctor's been trying to get me to take. It was engaging Molly in this process. And it was one of the really only effective ways we've ever figured out about how do you make the invisible visible. We see that people's metabolic data, their personal metabolic data, is probably our most underused motivational tool. And we use these words very importantly. We don't say, Molly, your A1C is high or low or good or bad. It's safe or unsafe. When we use these words, they're not judgmental. We're on the same side. And Molly might ask, though, what does it mean to be in an unsafe place? And we would use images. So here in California, the best images we can use are, well, images like this. So Molly, if your A1C is in an unsafe place, there's a fire burning inside. And your A1, getting that A1C test done, it's kind of like a smoke alarm has gone off. And the good news is, hopefully, we can catch it early enough so we don't have any damage to your body, your home. So let's take action. Now, the other thing we want to talk about is when we talk about these numbers with folks, we want to make sure we're being being not judgmental. And is all possible, again, remember all the blame and shame that so many of our patients are experiencing. We want to find ways to offer congratulations whenever possible. And that can be kind of tricky, but think about how we might talk to Molly about her A1C of 8.7%. Here's two ways of doing it. First of all, the traditional way. Molly, your A1C is still too high. Don't you understand the consequences? Do you want to go blind? Do you? Why aren't you working harder on this? So this is the common way, the traditional way. This is not going to be a very good way of actually engaging Molly and making much progress forward. It's going to probably just make her feel even worse and maybe not show up for her next appointment. But here's a way we can talk about, honestly, those same numbers, but do it in a different way where we can remove the shame and blame. Molly, you know what? It's great that you took the time to get your A1C test done. The numbers haven't moved much. It was 8.7% last time, which tells us that something different is needed. So in this message, we're trying to be just as sober. We're trying to focus on action being needed, but we can be on the same side as Molly without having to be mean about it. And we're offering congratulations. It's awesome you got this test done. So that's step 3. I'm going to zip on it, time's limited. Here's step 4. In many ways, it's one of the hardest ones, but one of the most important ones. Remember, we talked about how so many people feel hopeless and despairing. So how we deal with that is in our program, we like to do interactive things. We do lots of true and false questions. So the one we've been using the most, probably for more than 25 years, is this one. We'll ask every time we do a patient program, we'll say, true or false, diabetes is the leading cause of adult blindness, amputation, and kidney failure. And every time we do this, we see that about 95% of people agree that this is a true statement. And I can tell you, we've actually used this quiz with healthcare providers around the world using audience response systems. And again, it's 90 to 95% who agree that this is a true statement. But it's not true. It's false. Because to a large extent, it's not diabetes that's the problem. It's out of control diabetes. It's poorly controlled diabetes that's the leading cause of adult blindness, amputation, and kidney failure. And think about this in terms of what the corollary might mean, which is that well-controlled diabetes is in fact the leading cause of nothing. Now, I want to be honest with you. This doesn't mean on the left side of your screen that with good care, we can guarantee that you'll never develop complications if you have your A1C, blood pressure, and lipids in a safe range. But it does mean that with good care, this is what we've learned from all of our research in the 21st century, odds are pretty good you can live a long and healthy life with diabetes. Now, I can say that all day to my patients. They may or may not believe me. So I say, let's illustrate that with some real data. And I'm going to show you my favorite examples. It's going to take a few minutes to do, but it's really important. So let's first talk about type 1 diabetes, and we'll talk about type 2. So type 1 diabetes. Let's say if we could get a big group of people together with type 1 diabetes, and they've had it for 30 years, and they're in a healthcare system where they provide pretty good care, people with diabetes. So after 30 years living with type 1, what percentage of those people have run into the scariest complications of diabetes, like severe vision loss? So one healthcare system did that, and here were their results, and I'll explain them to you. What they found was this. Starting on the left side of your screen, after 30 years living with type 1, about 30% of this population already had severe vision loss or gone blind. The middle column, about 12% already had quite significant amputations. And on the far right of your screen, well more than a third of them already had significant nephropathy or kidney disease. So when we show this to live patient populations, most people go, yeah, that's not a big surprise. That's what I might expect living with type 1 after 30 years. But when I leave this up, eventually someone says, hey, why does it say 1978? I go, oh, I forgot to tell you, this is really old data. This is actually from the Steno Diabetes Center in Copenhagen. This is what we could achieve in 1978. Of course, there was no such thing as an A1C test or glucose monitoring or analog insulins, or actually even any good data, the good control mattered. But what about now? What about nowadays? Do things look like this? Well, let's look at probably the best data we have, which is from what's called the EDIC trial, which is the long-term diabetes control and complications trial. And so nowadays we can look at, again, another big population of people who've had type 1 diabetes for 30 years, and we'll especially focus on those people who are in the intensive arm. They've had really good ongoing care. So I don't mean to say that they're typical, but it's what's possible. So again, type 1 for 30 years, what percentage of those people now here in the 21st century have run into the same kinds of scary complications? Now their numbers, last time it was published, their numbers look like this. Yeah, severe vision loss, not 30%, 1%. And when this study was published, no one had gone blind. Amputations, not 12%, 1%. Nephropathy, not 35, 37%, about 6%. Not perfect. But this is what's possible. This is what's achievable. Again, these people have had really terrific care. So I don't mean to say this is normal, but this is what's possible and achievable. So good news, really good news. And we have a lot more. I wish we had more time to talk about it. But what about type 2 diabetes? So I'm going to show you one of my other favorite studies. This is much more recent, actually. It was actually just published a couple of years ago. And it looks at data from Sweden. Now, Sweden has this really great national registry. So they said, let's look at the people with type 2 diabetes in Sweden. And so they looked at all of them, all of them. It was more than 250,000 people with type 2 diabetes. And they said, let's compare that to a matched group of people, actually a larger population, who didn't have type 2 diabetes. Average age was about 60. Let's follow them for about 6 years and see what happens to them. So we could look at a lot of different outcomes, but I'm going to look at one with you just in particular, just to illustrate, and that's heart attacks. So first of all, this is the percentage of people who didn't have type 2 diabetes in Sweden, and what percentage of them actually had a heart attack in that 6-year period. Now, what's on the y-axis isn't going to make a lot of sense. I don't need to talk about it, but this gives you a rough sense of the percentage of that population that had a heart attack. What about people with type 2 diabetes? Well, that percentage of them who had a heart attack was huge. And so this is the kind of information which you may have heard about. So the conclusion is, wow, people with type 2 diabetes are at about quadruple the risk of having a heart attack if you follow them over the same 5, 6, 7, 8-year period of time. And so, yeah, you're at elevated risk, right? Well, not exactly, because I'm lying to you, because this actually isn't the people with type 2 diabetes in their study. This is a subset. These are people with type 2 diabetes who had elevated on all 5 of the major risks. In other words, they had elevated A1C above 7.0%. They had high blood pressure, high cholesterol levels. They had high what's called albuminuria, which again, sort of incipient at the beginnings of kidney disease. And they were smokers. But what about people who had none of that? What about people who were in a safe place with their A1C, blood pressure, lipids, albumin, and weren't smokers? What about those people? How many of them had heart attacks? Well, their rates were those on the far right. In fact, as you can see, it looks like they look very much like the people who didn't have type 2 diabetes. But I'll tell you, it's a big population. Actually, in that population of people with type 2 diabetes and no risk, they actually had significantly fewer or I should say, their risk of heart attacks was significantly less than even people who didn't have diabetes. So this is extraordinary. No one's ever seen data like this. Again, this is not a guarantee, but this is what's possible. That's why it's not diabetes that's necessarily the biggest issue. It's how to control diabetes. Now, I have to say, this is Swedish data. So the goal is, yeah, we want to help you get all your numbers in a safe place, don't smoke, and I'd probably add, move to Sweden. It would probably help even more because of their amazing healthcare system. But let me put it in the words of Sir William Osler, who said something 100 years ago. He was one of the founders of the Johns Hopkins Medical Center. That's, I think, just as true or more true today. It's my favorite quote from him. He said this, he said, the secret to living a long and healthy life is develop a chronic disease and take care of it. And that's why we're seeing these amazing changes now. It's possible. So think about this, how we can begin to help people with diabetes. Our patients know to hang in there, have a sense of hope, because we know that this is true and this is what's possible. Last strategy I want to mention, or step 5, is just about addressing discouragement. That we want to make it easier for people to be successful, because diabetes is to a large degree, of course, what people are doing at home. It's about behavior. And that means when they leave our offices, they should have a plan for action that's doable. We don't want to overwhelm them saying, well, here's the 30 ways you should change your diet, and here's all this other stuff you should do. If they're staring at you, looking at you blankly going, oh my God, or just saying, yes, doctor. Have we helped people have plans for action that are doable? And that should be focusing on the behavior, not the outcome. So the behavior of I'm going to make changes X, Y, Z in how I eat every day starting tomorrow. I think I can do that. As opposed to the outcome being, I'm going to definitely lose 50 pounds before I see you again. And we want to make sure there's some collaborative agreement before people leave our office. So oftentimes what I'll say to my patients before they leave is what you see in the bottom of the slide. So just to make sure we're on the same page, Mrs. Smith, can you tell me what's that one diabetes-related action that you're aiming to do over the next few months? We've talked about a bunch of things. Don't want you to get overwhelmed by this. What's that one thing that you think you can focus on and pull off? And let's make sure it's concrete. And when she says it's back to me, because it's concrete and because she's saying it out loud, there actually is some sense of commitment and it's more likely to happen. But the other thing I want to focus on is, again, I held up my one finger. Let's just focus on one thing you can do, because people are already overwhelmed. And if you want to be successful with behavior change, we know that it's one step at a time that can really make a difference. And finally, I want to add something else about this addressing discouragement, because people really get discouraged about medications. As I mentioned already, most people are not thrilled about meds, and it's one of the areas where we can really make a big difference. So one of the things that I like to highlight when I'm talking to folks is this, that if you think about the 100 things you could be doing tomorrow to take better care of your diabetes, it turns out, they're not equally powerful. They're not equally important. And it turns out that are you on the right medication and are you taking it is one of the most powerful things you can do to improve your health. And if you decide to blow off all my suggestions about taking your prescribed medications, but you really want to focus on things like diet and exercise, you may be beating your head against a wall, maybe. But it's, again, a conversation we need to be having. And for any medication that's going to be recommended, there's always going to be pros and there's always going to be cons or negatives. But the only reason I think that medication is going to be a good one for you is because I'm pretty convinced that the negatives, the cons, are going to don't outweigh the benefits. The cons are probably not as big as you think. Now, people are often skeptical and suspicious about medications, prescribed medications. I don't blame them. Let's talk about it, though. It's often really easy once we sort of shine the light of facts on these issues that people can begin to change their minds. It's just when we don't talk about it, it's hard to know. And finally, the last point on the slide, more medications doesn't mean you're sicker. And fewer medications doesn't mean you're magically healthier. Like my patients, I'd rather be taking fewer medications too. But if I decide that I'm going to skip my blood pressure medication, it doesn't mean I'm necessarily doing better. If I want to know I'm doing better, I need to check my blood pressure. And we see that people often try to measure how healthy or how not healthy are by how many meds they're taking. It just needs to be part of our conversation. Other thing I want to mention, of course, is we want to provide people with the tools they need for success. So ongoing support. We know that literally the more contact we have with our patients, the better they're going to be able to do. That's why we see that even studies that show that regular text messaging, even as automated text messaging, anything we're doing, sending out birthday cards to your patients, to let our patients know that we're out here rooting for them in any fashion actually leads to better success. Are we helping them be on the best medications? Are we helping them be on the right devices, like continuous glucose monitoring, so they can be successful? Do they know about it? Is it affordable? And as I've already mentioned, offering congratulations whenever possible really can make a big difference. So in summary, here's the steps we talked about. Assessing, meaning, Mrs. Smith, it's nice to see you. Can you tell me one thing about diabetes that's driving you crazy? Or using the diabetes distress scales. But let that be a door to open a conversation. The importance of responding with empathy, and how empathy has profound positive health outcomes over the course of years, as I mentioned with the Donba Miller study. How we make the invisible visible by the way we talk about people's numbers with them, about their A1C, about their blood pressure, about their lipids. And I think it's actually important to do it in a visible manner, in a graphical form. about how we share the good news and letting people know, like with these studies I shared with you. And again, all this data is available. I'm happy to send it to all of you. That with good care and effort, odds are pretty good you're going to live a long and healthy life with diabetes. And how we address discouragement by making sure people have plans for action that can really make a difference. So finally, I just want to let you know about our website, the Behavioral Diabetes Institute. If you're interested in learning more about the psychological issues of diabetes, and by the way, you're a healthcare provider and want more CE credits, we have a whole web series. They're 15-minute videos. There's a series of them available now. We have a new series coming out before the end of the month, and they're free. So they're available for you if you're interested in them in any fashion. So that's it for me. Thank you for listening. I'm really looking forward to Dr. G and any questions and comments from all of you. Appreciate it. And I will take my slides down so I can see you guys.
Can you see me yet? There you go. Dr. Polanski, Bill, that was fantastic. I was sitting here looking at my desk that's covered with a million notes and folders and just saying, I mean, you have somehow managed to compress everything I possibly could have wanted to say about this topic. It's so enormous. And I can tell you, and I want to reach out to our participants and tell you that this is what the Braden Diabetes Center was really started to try to accomplish, really. To the recognition that we can't take diabetes away from our patients. We wish we could. We know that they have to run with the ball, but we're sort of there to provide that team support. I don't like to say it's a team sport. That's silly. It belittles the severity of the condition, but it's a team condition. And I think that the missing team member is often this psychological, almost spiritual, that when I hear you, I almost hear what Dean Ornish says about heart disease. How yes, you have to take your meds and you have to exercise and you have to eat right, but you also have to kind of deal with stress and you have to get this love aspect in your life, which sort of smooths out these very rough edges. And I can tell you that I think the problem for physicians is that the lack of time, not the lack of desire. I know I speak for all of my colleagues by saying there's just so much they're putting in one visit. I don't actually know how primary care physicians can possibly take care of diabetes and anything else. But this is why, you know, we're there to help, and our team, our medical, sometimes it's the nutritionist, sometimes it's the nurse practitioner starting a CGM, as you said, or a new device. But what I'm hoping that your talk is going to bring to us is we're so close to being able to hire true professionals in the area of psychological health to work with us so that we can provide this support. Because if I hear you correctly, diabetes distress is not a separate disease. It's not a separate condition. It's not something we're going to look at the EHR and say, what box do we hit? But it's part of diabetes that we're not acknowledging. And take yourself off mute, Bill, for a while so you can join this conversation. And YouTubers, take yourself off mute so you can jump on. You know, you mentioned Sir William Osler. That's a quote that I love of his. And the other that's attributed to him, equally important, I think, is Sir William Osler said, listen to your patients. They'll always tell you what's wrong with them. Presented in your data and a lot of the papers I saw that we as docs, we just don't spend enough time listening. We're so busy trying to give them all this information that we're not listening and sitting back sometimes and just clearing the board and asking the patient the question, what's wrong? Like you said, what's driving you crazy? That can open all the doors.
And as you said, though, there's a terror in that, though, because you're so time constrained, right? I mean, you know, you got the, it's terrible, right?
But it is fantastic. And I thought I also took a look at that article that you mentioned about what we would call in medicine a legacy effect, in a sense of an initial intervention that is very positive communications with a group of patients early experience with diabetes, causing an effect 10 years later. That's been found for medications, that's been found for glucose lowering effects. There's something that happens that may be difficult for us ever to measure, but actually in some ways it has been measured. There seems to be a legacy effect. In psychology, it's you measure things differently, but it seems real.
Well, and I think another way of thinking about it is there's so much payout, there's so much benefit if we can help people do well at the beginning.
Right,
I
right.
mean, it's like with your kids, right? Teach them good habits early
Right.
on.
And as an endocrinologist, I often don't see patients at the beginning. I see patients when they're 44 years into their disease, and there are already a number of disasters. But in a sense, that's a beginning for me. And that's a beginning for us. And I think that's true of all of us who are seeing our diabetics now at Learn Health. I think we have to realize the next interview, the next office visit is a possible beginning. And I wondered if you could just say a little bit about how you think these considerations have been modified in the time of COVID, where we are experiencing our interviews on telehealth, where patients are having to struggle with yet another hurdle, which is just getting their supplies without going to see the doctors. Are they getting their devices? Are they getting their medications? One of our questions from another endocrinologist asked, what about the contribution of medication costs and the stress that causes? Is that something that we can modify, and how serious is that? How has COVID changed this? What do you think how could we address this better?
Yeah, there's actually been some surveys done. In fact, with our colleagues at UC San Francisco, we just published something, I think it just came out yesterday, where we surveyed, I think about 800 folks with type 1 and type 2 about their experiences since March. And it's really a mixed bag. Some people are, well, I don't think anyone's having a great time, but actually some people are actually doing better with their diabetes. Some people are actually enjoying their contact with their healthcare providers more. Like their healthcare provider seems a little more real to them because they have like the cats wandering by the screen or behind them.
It jumps on your lap.
Yeah, and they don't have to go deal with downtown traffic or whatever it might be. And there's others that feel, you're right, just more profoundly disconnected, more profoundly isolated. And there's certainly a lot more depression, which is making it a lot harder for people to succeed with it. Dealing with any chronic illness. Depression is one of the most powerful ways we can sucks the oomph out of everybody. And we're all just counting the days, right? I mean, this has been really tough for everybody.
Right. It's as if we're having to define a new interaction, and it's taking place virtually like this. That's why we were so excited and grateful to you for being willing to participate in a very personal educational session like this, because the option would have been to just cancel our event, which we usually hold outside in a wonderful garden in town. But I think if we can break through these barriers during COVID, that's going to be very important. Breaking through the stress of the cost and the delivery of devices. I don't know, Kelly, tell me what you think. I mean, someone asked you a question that you sent to me, and it spoke to what Bill said earlier about having diabetes is a job. Well, in every job in the world, you always get a vacation. And the question was, can I ever take a vacation from my diabetes? I'm going to kick that one to you, Kelly.
Yeah, I think Bruce and I would probably both jump on that one. I, as the clinical manager, yes, I'm a professional, but I have type 1 diabetes for 35 years. I think Bruce can join, and I think around that same time frame of decades, and there is never a vacation, ever. I think a lot of what Dr. Polanski spoke about as far as, the quote of having a chronic illness and being able to manage it effectively, that's what the primary physician told my mother and father in 1985, that this will kill your daughter if blah, 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 but you can do this. And if you have to have a chronic disease, diabetes is one that can be lived with for a long, healthy life. So that's not to say that I haven't personally dealt with issues and problems and everything else that every other patient with diabetes deals with. The hassle, I think my colleagues on the call now have heard me on the phone fighting with insurance companies and mail order prescription pharmacies trying to get what I need to live a long, healthy life. So yeah, there is no vacation. And that was the most interesting question posed to me of, you're right, there is no vacation ever from it. Bruce, do you have other things to add? I'd love to hear your perspective on that same question.
Bruce, what do you have to say about that? You've dealt with this for decades as well.
No, just 35 years. Kelly is right. It's a perplexing disease. We can deal with it, and at the same time, wow, I've been fooled by it all the time. I've lost my driver's license twice. I had hypoglycemic issues. I ran off the road on Highway 280 going 80 miles an hour because I passed out, and somehow I survived. So, and of course, the highway patrol loved it because they found some syringes in my glove compartment. They thought, oh, we got some here. And so anyway, I ended up in the hospital, and I've learned over the years to get more cautious. And, the best deal is, this is a lifelong thing. I'm doing Libre right now, and I know Dexcom has a great application. And back when I got it, and Kelly, when you did, you had to stick your finger 5 or 6 times a day. I never enjoyed that, and sometimes I didn't do it. And but at some point, that's what you have to do. And I work with Matthias Haybrook at UCSF. I don't, and they say, oh, we got some cure, and I don't think it's going to happen in my lifetime. So I'm just going to have to deal with it. And anyway, it's a perplexing disease, and Dr. Gaudiani has told me never to get in my car without checking my blood sugar. And I think that's a really good.
Especially not after 18 holes of golf.
Yeah, or after a couple of beers. That's anyway. Good deal.
Well, I think we've hit upon so many key issues in your talk. The things I wrote down, the importance of acknowledgement. Even when a patient comes to me with the worst data in the world, I just take a deep breath and I go, well, the good news is you came to this appointment. And if you hadn't, we wouldn't have missed the opportunity to figure out what the heck's going on. Because, this isn't what you want. So I think that we have to start from that point of encouragement. And yet, I'll say, as a physician on the other side of it, physicians are running behind. They're frustrated. They want to see their patients do well. They're being measured by their health institutions in terms of outcomes. Gee, how come your patients aren't doing better? How come those blood pressures aren't this? And you want to say, stop. This is a lot more complicated than you think. Right. So I think there's frustration on both sides. I throw that out to my patients sometimes when they're frustrated with their docs, and I just say, we're human too, and we fail you sometimes. And I make the analogy often, something I probably shouldn't do, to sports, because I'm the girl that hardly knows the round ball from the one with the points. But I do know from watching my share of football games that one guy takes the ball into the end zone and, they cheer for him. But that guy has so many people around him helping to make that touchdown. And way on the sidelines, he has the guy with this. And that's what I say. That's what I am. We docs and teachers, we can be your coaches, but it's going to be your game.
Yeah.
And at the last minute, you gotta call the plays.
Linda, you know nothing about sports. Don't go down that road. I mean, you asked me once if Seattle had a football team, if they played Stanford. Oh my God.
Ah, that's embarrassing. Oh my God.
My hardest critic and one of my best friends. It's so true. It's so true. I want to ask you, someone asked with a question just now, would it be better if we had Medicare for all and patients could have long-term relationships with their primary cares and get their meds and equipment without having to worry about the cost? Omar.
Let me think about that one. Yes. And by the way, I wish we had time to talk about, Bruce was talking about hypoglycemia. I think there's important things to talk about. I'd love to talk more about the importance of diabetes vacations. But yeah, these are big issues in terms of affordability, the social determinants of health. I mean, all these things are just crushing, people if they can't afford anything. And that's a political problem. That's not a personal problem. So
Right.
Everyone can stay angry and stay active about that.
Talk about that for a minute, Bill, from the psychological point. That's been a big thing for me as an endocrinologist. The patients will just say, look, I would rather have my blood sugar run a little too high than too low. I can't afford. I'm a mom, or I drive, or I do this or that, whatever. No one wants to have hypoglycemia. It's underappreciated as a tremendous underlying fear factor.
Yeah. Yeah. I actually just gave a lecture about that this morning. Yeah. I mean, we know, I can tell you of people with type 1, about half the people with type 1 in this country are pretty fearful about lows. But they aren't necessarily keeping their blood sugars too high. Many of them are. Many of them are just fearful. And so they constrain themselves in other ways. Like I can't exercise anymore, or all sorts of things. And like what Bruce went through, it's very easy to have one bad event happen and be really severely traumatized and have everybody in your family traumatized. And then you're going to, do things that, it's hard to find that point of compromise between, I want to be safe from highs, but safe from lows. But I think one of the ways we think about it is it's not helping people to be less fearful of hypoglycemia. Really, the goal is what do I need to do, or what do you need to do as an endocrinologist to help people feel more confident in their body? That you want them to help regain confidence that they can trust their body to drive a car, to be safe when they're alone, to go to sleep at night. And we do that with continuous glucose monitoring. We do that with all the tools we need, the right types of insulins, with pumps, with procedures we have, like called blood glucose awareness training, making sure people have a number which they actually treat. There's tons of stuff we can do to help people gain confidence back, and that's everybody needs.
Sure, I think that's also important. And we're seeing a panoply of tracking devices coming out now, and I think that is also sometimes overwhelming. That people feel like they have to keep control of their blood pressure, measure their sugars, measure their carbs, measure their foods, measure their exercise, track their activities. And I wonder how you have used all these various diabetes education tracking devices. Are there certain things that you feel work better than others in your experience from the point of view of limiting the diabetes distress aspect of it?
Well, I have to say, I think you're talking about a Northern California problem. Which, thank God, which is this idea of what they call, especially the Silicon Valley people call it the quantified self.
Yeah.
And that they really need to keep track of everything. And it kind of intersects with people who are very much achievement oriented and somewhat perfectionistic, and think that diabetes is really just a numbers game. And it gets them in severe trouble. Right. So we're big believers in how do you help people take breaks from that technology? I think about what Kelly said about there's never a vacation from diabetes. So Kelly, I want to challenge you. I think the dirty little secret about diabetes is that everybody takes vacations from their diabetes. Everybody does. But there's two different kinds of vacations. There's really, really unsafe vacations. And those are typically the patients I see. Those are the people who like basically blown off their diabetes care for a year or so. That's horribly dangerous. But there's people who I meet all the time who figured out these clever little ways to have little bits of time off. Because if a vacation is a good vacation, it's restorative, and they manage to do it safely. Like, I'm going to let my husband worry about my blood sugars for the next couple hours. You know what I mean? Or I'll let someone else drop the insulin tonight. So it could be a tiny little thing. And so we call that safe diabetes vacations or glucose getaways.
That sounds great.
And we shouldn't be afraid of that. We should be encouraging that if it's done safely, though, because
Right.
you deserve a break. Everybody does.
Right, but that's again, Kelly.
I'd have to agree. I think that diabetes oftentimes is a task-driven, mind, intellectual, that numbers game, instead of being a really heart-driven life. If I'm okay to say, my kids are like, Mom, what's your blood sugar? Is that the right insulin at bedtime, Mom? Don't take the wrong one. Yes, dear, it's the right one. Thank you for keeping an eye on Mom. But it's moving away from that task-oriented, because you can't do that for life. You can't do that for decades. I don't think that's, even without having diabetes, what other person without diabetes can do those types of skills every day at every moment, all the time? So I will take your advice, Dr. Polonsky, and I might have to send you a little message that I took a glucose getaway.
What was that? A glucose getaway? We're going to quote you on that.
Well, and I encourage people to get creative. Help find a way to do it safely. Do it with your healthcare provider, but find a safe way to give yourself a mental break. And it can be a minute, it could be 5 minutes, it could be an evening out, it could be anything. But this is doable, and you need it.
Detach and make it okay, not something you have to apologize for.
That's why our glycemic goals are not to be perfect. To have time in range of 70% or have an A1C of less than 7.0% doesn't mean being perfect.
Right, because we're human.
Yeah,
I have a feeling we could sit here and pick your brain for a very long time, but I know our time is coming to an end. It's been so informative. I can't imagine that all of our physicians and every single one of our participants doesn't join me in thanking you so sincerely for taking the time out with us. I know we're relatively small on the spectrum of what you do, but we're really very, very grateful to you. As we're building our program, we look to you. We've looked to Earl Hirsch and his program and many others around the country, and we're going to keep going forward to create the best atmosphere and culture of diabetes awareness that takes into consideration both all the science and all the humanities that you're bringing to it in combination. So important. I want to thank our panelists, Bruce, for helping us to found this and continuing to support it every day. Kelly, for not only being side by side, but usually one step ahead of me. Thank you so much for everything you did to make today possible in this time of COVID. I want to thank our IT support staff who helped us so much and rehearsed us so that we would actually get our mics and our videos on and off at the right time. And also to the media and marketing department at Marin Health. They did a fantastic job. I also want to give a shout out of support really to our new administration, to our new chief executive officer for believing in us, Dr. David Klein, and to Dr. Eric Pfeiffer for all he did for us last year in helping with the administrative aspects, and to Tori Murray, our own administrator. And I also want to thank the Marin Foundation for helping us over the years. It might not sound like a lot to some of the big executives, but this community has raised over $7 million just since in the last 10 years for the Braden Diabetes Center effort. And all of that has gone into improving care. Thank you to our families and to our friends. And last but not least, thank you to our patients who continue really to inspire what we do every day. Thank you all. Good night.
Thanks.
Good
Thank
night.
you.
You guys.
I'm gonna have some chocolate cake. Thank you so much.
Right on. Good
All
night.
right.
Thanks,
Yes.
folks. Thank you all. Good night. Thanks, Bill. Thanks, Kelly. Bye, Bruce.